So I'm going to do a screen recording so we can hopefully make sense of this a little bit. One thing I want to preface is that sometimes these can be challenging because there is not a straightforward answer with which survey is best. As you have seen, there's some conflict in some of your studying materials. And part of that is because, especially at elementary school age, we inherently have mixed dentition, which is a pitfall of having one type of indice that's meant for permanent teeth only and one that's meant for primary teeth only, right? So let's talk really quick though about the difference between a T and an S, if you're doing teeth or you're doing surfaces. So one of the main differences is that if you're doing surfaces, you're going to need radiographs, right? So that you can clearly note interproximal surfaces before decay is so large that you can see it, right? So that is your main difference of when to use a T or when to use an S. And that applies to Dmf and Def options. The other instance, right, is to remember that DE is looking at extraction needed, right? It does not represent teeth that have been extracted. So DEF is looking a little bit more at current disease, right? So they're looking at, some of it is because of the extraction needed part, a little bit more of like treatment needs, slightly more specific than DMF. So you're not going to note an E for teeth that are missing. You're only going to mark an E if the tooth needs extracted. So in my professional experience, we have not used DEF type of surveys and indices because we are not the ones as dental hygienists who are doing the surveys to determine if a tooth needs extracted or not. I may know very well if like there's root tips remaining on a decayed tooth that should be extracted, right? But it is not something that's technically within my scope of practice to be saying if a tooth should be extracted or not. So I would say from a dental hygiene professional experience, that's probably why I've used more Dmft scores than Deft scores. A lot of the settings I've worked in, we did not have access to radiographs, so we couldn't do surfaces. So we were just looking at the tooth as a whole. A tooth versus surface indice also is much faster because you're looking at like 20 to 28 teeth instead of over 100 surfaces, right? So that also makes a big difference there. So then let's talk about a couple of your specific questions you had. One thing I will say that can be frustrating, like I said before, is that you're getting a little mixed information, right? Because here it's saying that choices A, B, and C are indices for price. I would tend to agree more with Mosby in this scenario when it has to do with uppercase rather than lowercase, because one, they were talking about, I guess they were talking about just elementary school children altogether. If they have permanent teeth, then professionally I have used the uppercase indices rather than lowercase. However, So that can be an age thing, right? Like if they're talking preschool, like like Head Start programs, then I would definitely be using lowercase because those are younger children that should not have permanent teeth at all, right? Even kindergartners can really vary. First graders, usually by then, most children have at least some adult teeth. And I understand how student RDH was saying that because they have, let's see if we can find their explanation here, that is useful in assessing caries rate in primary teeth, right? And the uppercase is used for adult dentition, and that elementary school children will have more primary teeth than permanent teeth. My argument there is that they did not specify an age group of what they were going for. And while many elementary school children will have more primary teeth than permanent teeth, there are many of them in like fourth and fifth grade that is not true. They may only have 8, maybe 10 tops. They may be like literally half and half of having permanent and primary teeth. So I think one of the things to remember too, though, is if they have an option for you that includes an uppercase and lowercase, then that would be your best option. For me, I would say I lean more towards what Mosby says as far as DMF scores that you're doing on permanent or primary teeth. If they're elementary school, I'm going to be using a all caps type of score. Maybe you'll get lucky and they'll give you the best and they'll give you a combination of the two, because that would truly be the best option. So now let's talk about your same school that needs fluoride. Like, what is the most cost-effective way of resolving the decay issues? So the key thing in this question is cost-effective. So when we're talking about cost-effective, I would eliminate a school sealant program right off the bat because they can be very costly. A lot of times you've got to pay people to do those. They have to come into the schools, or children have to be taken out of class. You have to have a lot of supplies. You also can't do sealants just like on the fly. You've got to have like a mobile dental unit of some sort, right? So things start getting more expensive. To put that into a price perspective too, like a mobile dental unit, if you get a portable kind of suitcase one, like a quality one can run from like a couple $1,000s, to like 5 or more. So those can get really expensive just for the unit alone. And then you have to have a lot more supplies, your sealant material, all your extra things that come along with that. And the big thing is that you have to be able to have a licensed professional apply those sealants. So that inherently makes it more expensive. So we know these individuals are on well water. So then community water fluoridation would have no effect because they don't get community water. They get water from their individual properties, from their wells. So we can cross out A and D right away. Now, there could be some arguing about the cost efficiency of a fluoride rinse program versus fluoridating the school, right? So a fluoride rinse program initially is going to be far less expensive than paying for the equipment and the plumbing and things like that to add fluoride to the water that the children are drinking at school. However, in the long term, fluoridating the water at the school would be the most cost-effective option, because you wouldn't need to have permission slips for children, right? You wouldn't need need someone to administer the fluoride, which in some settings, again, might require like a dental hygienist or a dentist administering that, depending on the Practice Act and laws of that state. So, in the very long run of things, a school water fluoridation program would be the most cost effective. But I mean, a fluoride rinse program initially could be also very cost effective. But when we're looking at the big picture, right, the next best thing to having a community water fluoridation is fluoridating the water that those children are going to drink majority of the year, right, while they're at school. But so that's kind of the breakdown there. I'm impartial to sealant programs myself, so I like that you're thinking about them because they're very beneficial. But when we're talking about cost and we're looking at a list like this, your school water fluoridation program is going to be the most cost effective for helping with decay issues. All right? If you have any other questions, email me, text me. I'm happy to help answer them.